Welcome to this explainer. Today, we're diving into a really fascinating journey. We're looking at the path from the clinical bedside all the way to the legislative boardroom. We're going to explore exactly how macro-level national data intersects with the frontline, micro-level experience of healthcare practitioners to actually shape the policies that govern our nation's health. So, if you've ever wondered how the day-to-day realities of patient care actually make their way up to Capitol Hill, well, you are in the exact right place.
Okay, let's dive into this. 90,000. Now, that isn't just some random statistic. That's the literal number of addresses sampled every single year by the U.S. Census Bureau. It's absolutely foundational for establishing the true landscape of our nation's health and wealth. Because think about it, before any policy is ever drafted, lawmakers really have to rely on this nationally representative snapshot just to understand what's actually happening in the homes of everyday Americans.
And that brings us to Section 1, Tracking Poverty and Coverage, and how we measure the nation's health. Because, before we can even begin to fix systemic issues, we need the macro-level data that allows policymakers to identify those issues in the first place, right? And this brings us to a really crucial tool, the Current Population Survey Annual Social and Economic Supplement, or we can just call it the CPS ASEC for short. This report provides the essential foundational data on things like income, poverty, and health insurance coverage. And what's really incredible about this survey is just its absolute depth. It actually collects information on income from more than 50 possible sources across a huge range of demographic characteristics, things like family status, age, metropolitan residence, the whole shebang. This is the bedrock data that policymakers rely on to understand the financial and physical well-being of the entire country over the previous calendar year. But how is poverty actually measured within that massive data set? Let's break down two very different approaches here. Over on the left, we've got the official poverty measure. This one has been used pretty consistently since the 1960s, and it's calculated simply by comparing a family's pre-tax money income to an official poverty threshold. Pretty straightforward. But look at the right side, the Supplemental Poverty Measure, or SPM. Now, this is where it gets highly practical. The SPM doesn't just look at pre-tax income. It actually includes the very real effects of government safety net programs and assistance, and then it subtracts necessary expenses. So it really captures the real-world impact of short-term current events and government interventions on a family's actual tangible resources.
Moving right along to Section 2, from bedside to boardroom, the practitioners navigating the landscape. All right, so now that we understand the massive macro demographic data that defines the problems, let's zoom in. Let's transition to the micro level, where individual patient-provider interactions become the real catalyst for systemic change. Just look at this number, 4.2 million. That is the number of registered nurses currently on the front lines of healthcare right now in the United States. I mean, if you want to talk about a massive force capable of driving systemic change, this is it for sure. We kind of tend to think of policy as something created exclusively by lawyers and politicians, but there are 4.2 million clinical experts out there who possess deep, firsthand knowledge of how the healthcare system actually works on the ground, and honestly, more importantly, where it fails.
And you know what? Those clinical skills translate perfectly to the legislative world. A seasoned Capitol Hill legislative director actually hit the nail on the head, saying talking to constituents is probably pretty similar to talking to patients. And if you think about it, yeah, it really is. Congress is essentially like a giant hospital trying to solve massive, complex issues where the entire nation is the patient. Nurses and clinical practitioners spend their days assessing problems, communicating complex information, and advocating for vulnerable people. Actually, those are the exact same skills needed to draft impactful legislation and navigate the halls of Congress.
So that leads us right into Section 3, the 4 policy capitals and tools for advocacy. Now, what's really interesting about this slide is how it breaks down the transition from clinical practice to policy leadership.
The 4 capitals framework maps this out perfectly. First up, we have intellectual capital. Now, because of their rigorous education and clinical background, healthcare providers naturally excel here, right? They are the health experts in the room. But to really influence policy, they must actively build the other 3. Social capital is all about networking, showing up early to meetings, building relationships, finding like-minded advocates. Then there's financial capital. And this doesn't necessarily mean just writing huge checks. It's really about investing your valuable time and resources into professional associations and advocacy campaigns. And finally, political capital. This is understanding civics, identifying the key stakeholders, and learning the actual nuts and bolts legislative process of how a bill becomes a law. Mastering these 4 areas That's exactly how a bedside nurse transforms into a boardroom powerhouse. Let's move to our next section and see how this builds into a specific example with case study 1, fixing the vaccine gap and real-world legislative impact. And this brilliantly illustrates the exact problem that needed fixing. Okay, so under Medicare Part B, older adults can get vaccines for the flu and pneumonia with absolutely no copay. 0. But under Medicare Part D, if a senior needs a recommended vaccine like the one for shingles, suddenly they face a copay that can range up to $120. Now, research shows that even a tiny $5 to $10 copay acts as a massive deterrent for older adults living on fixed incomes. So we end up spending millions treating vaccine-preventable diseases simply because a small copay prevented someone from getting a preventative shot in the first place. It's a classic, frankly dangerous gap in the system. So how does a frontline perspective actually fix this? Let's walk through the step-by-step life cycle of the legislative solution. Step 1. A single constituent highlights the problem via a letter to their representative. Step 2. A nurse serving as a health policy fellow in the office investigates and discovers, hey, there's an existing Senate bill to fix this, but a glaring gap. There is no companion legislation in the House. Step 3. By utilizing that social and political capital we just talked about, the office gathers bipartisan co-sponsors from completely across the aisle. And finally, Step 4. The Protecting Seniors Through Immunization Act is officially introduced. This whole step-by-step process shows how one single letter, when combined with clinical insight and legislative action, can reconcile Medicare vaccine costs for literally millions of people. Which brings us to case study 2, shaping the health workforce and building cultural competence. Because, influencing policy isn't just about changing billing codes or copays. Frontline practitioners are also actively influencing the future demographics of the healthcare workforce itself. Just consider another major initiative spearheaded by a nurse policy fellow, drafting a House resolution to establish National Hispanic Nurses Day on September 22nd. This came about through direct collaboration with the National Association of Hispanic Nurses. It's a formal legislative effort to celebrate Hispanic nurses and, really more importantly, to actively attract more diversity to the clinical field during Hispanic Heritage Month. So the crucial point is this. Why does a resolution like this actually matter? Well, first, it ensures the provision of culturally competent care for diverse populations. When practitioners share a cultural or linguistic background with their patients, like, say, speaking fluent Spanish in a district that is 70% Hispanic, the quality of care improves drastically. Second, it directly addresses the current very real underrepresentation of Hispanic and Native American providers in the healthcare workforce. And finally, it serves as a beacon to attract new men and women to the nursing profession. Basically, shaping policy means ensuring the workforce actually reflects the beautiful diversity of the patients they treat every single day. Which brings us to our final takeaway and really the ultimate question for you to chew on. With health in all policies, how will you use your expertise to change the system? Whether you're analyzing macro-level Census Bureau data or you're a frontline practitioner seeing the gaps in patient care firsthand, you have personal capital to invest. We've seen today how clinical skills translate seamlessly to legislative action and how everyday people can impact policy right in their own backyard. So, what's your vision going to be? Thank you so much for joining me for this explainer. Keep learning, keep questioning, and I'll see you next time.